So this series discusses recent updates in dementia research and highlights dementia research studies occurring across Toronto. I wanted to tell you a little bit about the Alzheimer's Society of Toronto. So the Alzheimer's Society of Toronto provides information, education, and support to people living with dementia and their families and friends, healthcare professionals, and the general public within the M postal code. We do service all dementias, and a diagnosis is not required to access our programs and services. Our programs are currently being offered in person as well as virtually through Zoom and the e-learning platform ALS Educate. So to learn more of what we have to offer, please visit our website at www.alz.to and take a look at our calendar of events and upcoming offerings. I'd like to also introduce our partner, the Toronto Dementia Research Alliance. Established in 2012, the Toronto Dementia Research Alliance is a collaboration amongst the University of Toronto, Baycrest, the Centre for Addiction and Mental Health, Ontario Shore Centre for Mental Health Services, Sunnybrook, Unity Health Toronto, and the University Health Network. Together with its partner, the TDRA aims to strengthen the link between basic science and clinical research to better understand, prevent, and treat dementia. So I'd like to pass it on to Natalie, who will continue on.
Great, thanks, Julie. So if we can move to the next slide. My name is Natalie Dren. I'm a research coordinator with the TDRA. And what we've done is partner with ASD on an initiative to try to make research a little bit more accessible to everyone. So the Toronto Dementia Network, or TDN, is a website that lists dementia-related programs and services across Toronto. And on this website, we created a section called Research Studies, which lists dementia studies that are open for participation across the city. Each study that's listed there is led by TDRA affiliated scientists, and all the studies have been approved by research ethics boards. So there are studies for people with Alzheimer's disease and other types of dementia, mild cognitive impairment, those at risk of developing dementia, as well as healthy volunteers and caregivers. So the studies are all summarized in plain language, and to get started, the website link is shown on the slide in orange. Information about the TDN can also be found on both the AST and TDRA websites if you'd like to learn more. You can move to the next slide. So on the website, there are two main pathways. You can browse for a study using search terms, filters, and quick searches. And when you find the study you're interested in, you can fill out the contact form and you'll be connected with the research team who will enroll you in the study if it's something you're eligible for. Or at the bottom here, if you're not sure where to start, you can fill out a questionnaire to be matched to a study. And any information you enter on the website will be securely stored and protected. Next slide. Okay, and this is what the website looks like. When you're on the page, if you're looking for something specific, for example, Alzheimer's disease studies, you can type it in the search bar along the top. You can hit submit with that term, or you can apply more filters like the type of study, the age group, target population, or the study location, and then hit submit from there. Alternatively, you can just do a quick search using the quick search buttons we have in the blue boxes. If you'd rather fill out a questionnaire to be matched to a study, click the Match Me to a Study quick search box, or you can scroll to the bottom of the page and you'll see this orange button that says Can't Find a Study You're Interested in, and that will also take you to the questionnaire. Each study summary, as shown in the All FTD study example on the left, describes what the study is about, who can participate, the location, and the time requirement, and that's all in plain language. The studies that are being discussed today are both listed on the TDN, so you'll be able to read more and connect to the study teams there. Okay, next slide. Great, and now I'd like to introduce our speaker. Before I do, just a reminder to keep any questions till the end of the webinar for our question and answer period. That being said, you can pop questions into the chat as we go through, and they will be answered at the end as well. So we're grateful to be joined today by Dr. Carmela Tartaglia, who is an associate professor and clinician scientist at the Tan Center for Research in Neurodegenerative Diseases at the University of Toronto. She maintains a cognitive behavioral clinic within the University Health Network, where she sees people living with neurodegenerative diseases and post-concussion syndrome. She also holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. So welcome, and we're looking very forward to hearing your presentation.
Thank you. Well, thank you everybody for, taking up your lunch hour with this. I'm going to share my slides. Oops. Did that work?
No, not yet.
Okay. All right. Let me go. Okay. Let me escape. And go back here. Share. Okay.
Here we go, so we can see
Do
PowerPoint.
you see it?
Perfect.
Okay.
Yeah, perfect.
Okay, so thank you. Actually, I am just going to plug in my computer, make sure that it lasts the whole time. Okay, so thank you for inviting me to talk to you about an area that is quite dear to my heart. I see patients with frontotemporal dementia, and most of my research program is dedicated to this. So we'll just go over, what this is and the names for them, and then go over, the different pathologies that are associated with it, and a little bit on the genetics and research opportunities. So I always like to start my slide because there seems to be a lot of confusion in the world about what is dementia and what are these other diseases. And so, I think it's important to always remember that dementia is an umbrella term. It basically is, we detect dementia. We detect a mild cognitive impairment. It actually is not a diagnosis of any real sort. And so, the patients that I see, a lot of them actually get misdiagnosed because they're told they have dementia, and a lot of them are told, well, if it's dementia, it's got to be Alzheimer's disease, and that's not what they have. So it's really important for people to understand that, when somebody says there's dementia or a mild cognitive impairment, that's kind of like the first step. The next step is, what's the cause of it? Almost the more important question in terms of when you wanted to think about treating something. And there's many different causes. Everybody knows Alzheimer's disease and Parkinson's disease as causes of dementia. Frontotemporal dementia is less well known. Things like chronic traumatic encephalopathy, what happens in brain injury, vascular disease. But there's also other causes. Things like multiple sclerosis can cause dementia, brain trauma, HIV infection, or any type of infection, a metabolic disorder. So it's important to just think about that. And like I said, dementia is really not a diagnosis other than to say, that you are not able to do what you used to do before. And it's really related to cognitive and behavioral changes. So it's a detectable change. We usually detect it with tests, and it's usually detectable in the sense of a change in memory or thinking, but it could also be a change in behavior or language. In frontotemporal dementia, there's a lot of confusion because there's different words to say similar things, and so the way we usually think about it is when you say frontotemporal dementia, you're actually thinking about the clinical syndromes and all of those, and we'll go through them. And when you talk about frontotemporal lobar degeneration, it's actually like the pathological change, like what happened to the brain to give you the dementia. And some of us also think about frontotemporal spectrum disorders just because there's a lot of them to think about when you're thinking about this family. So this is the family of frontotemporal lobar degeneration. There's actually 6 different syndromes that belong to it. And they're mostly based on clinical. So what is it that you see? So there's like a behavioral variant. There's aphasias, there's motor, and we'll go through each one of them. And there's motor neuron disease. And then what we also think about is like, well, what's the pathology? Like, what's the cause of the changes that we see? And so it's also a very heterogeneous group because it's got 2 main pathologies, which are the middle ones called TDP43 and tau. But then there's also Alzheimer's disease pathology that can cause these syndromes, or this other one called FUS, which is very rare, but also causes motor neuron disease. So we'll go through these, but it's just to kind of give you a lay of the land. In terms of prevalence, you know, anybody who's got a member of the family with frontotemporal dementia says, well, you know, nobody's heard of it. But actually, that's probably because of, you know, misdiagnosis or, you know, missed diagnosis. Because actually, when you look in younger people, so people aged less than 65, the prevalence of frontotemporal dementia is actually as common as Alzheimer's disease, because there is such a thing called young onset Alzheimer's disease. And so in the younger group, they're equally common. And some people actually think that there's even more. And it's very difficult because when you're, you know, because I told you there's all these different syndromes, really getting a good sense of how many people have this condition is hard, because originally there were only 3 syndromes that belong to this condition, and now there are 6. So you could imagine the numbers have even gone up. And so when you look at the different studies, you get different numbers. But all to say, it's not as uncommon as all that in the younger group. The main family, I guess the original family, had only 3 syndromes. And it was kind of easy because there was a behavioral variant. So just like the name implied, it was behavioral variant frontotemporal dementia. It sometimes went by the name of Pick's disease or frontal variant FTD, but a change in behavior landed you with this diagnosis. There are 2 of them that are actually aphasias. So that means there's a language problem. And depending on which part of the brain got affected, you would end up with a different clinical syndrome. So in the middle, it's called semantic variant primary progressive aphasia. And basically, you know, it's that what we call a temporal lobe that gets affected. In non-fluent variant, and we'll talk about these a little bit more later, it's the left inferior frontal gyrus. So a different part of the brain, the motor speech part of the brain is affected. And so what you get is somebody who can't actually say words properly. Whereas when it's the temporal lobe, the one in the middle, what you get is somebody who doesn't understand words. So, oops. Then it was realized that maybe we had it wrong. This family actually was made up of more than the 3 original syndromes, that when we looked at the brains carefully, we saw that actually there were 3 other syndromes that shared a lot of the same characteristics in terms of the pathology. And so now we know that this is a family of 6 syndromes. One of them is called frontotemporal dementia with motor neuron disease. That's ALS. There's Corticobasal syndrome and progressive supranuclear palsy. So let's start with behavioral variant. So behavioral variant is really, you know, based on, like, well, the name kind of gives it away. This is a behavioral syndrome. So most of these people, actually, you don't have any memory problems. You don't have any language problems. What you do get is a change in personality. They'll be, you know, disinhibited, talking to strangers. They could be apathetic, giving up their hobbies, their work. They could have decreased empathy, not really being very caring to their family members anymore. They could develop these kind of repetitive activities, like, you know, hitting things or pacing or picking at their skin. Their diet changes. They'll crave sweets or develop some food fads, oftentimes eating more. And if you tested their cognition, what you would find is pretty intact memory in many of them, but you would find deficits in what we call executive function. So that's like concentration, that's being able, you know, planning, organizing, those kinds of activities. And of course, you know, we looked at the brain, why those changes have occurred. And, you know, sure enough, we would find that the shrinkage of the brain is in the frontal areas of the brain. And those areas are, you know, the important areas for planning, organizing, judgment, problem solving. And so, you know, this is why these people have profound changes in their personality. And, you know, if you just have the symptoms without the significant brain change, it's called possible behavioral variant FTD. But if you also have the brain changes, then you get a more certain diagnosis, and that's probable. And, you know, these diseases are also associated with genetic mutations, and we'll talk about more of these, more of this later. In terms of the underlying pathology, this is a very difficult group to predict the underlying cause. There's two main causes, which is TDP43 and tau, but there can also be other types of diseases that give you the same syndrome. And this is a problem for when you think about when you want to treat somebody, because if you want to, you know, do something like target those actual bad proteins, then you have a problem because you can't figure out what the person has. It's the most common of the three clinical syndromes, and in the spontaneous non-genetic, it is more common in males versus females. There's a pretty early age of onset, and it progresses quite rapidly when there's motor neuron disease associated with it. That's the ALS, and it can have high genetic susceptibility. And like I said before, that now we know that people with motor neuron disease, ALS, can have FTD features, and people with FTD can also have motor neuron disease features. What about these aphasias? There's actually three primary progressive aphasias, and one of them is actually caused by Alzheimer's disease. It's called logopenic variant, and we're not going to discuss that one more here. But there's two of them that are caused by frontotemporal lobar degeneration. And when we talk about aphasias, what this means is that a person presenting with this problem for at least the first 2 years is primarily, if not exclusively, having a language problem. So they can't have memory and thinking and walking. No, then it's not called a primary progressive aphasia. It has to be really that the biggest problem they have, and often the only problem they have, is with language. And so the two that are caused by frontotemporal lobar degeneration are, one is semantic variant and the other one is non-fluent variant. And so in semantic variant, you could actually have left-sided or right-sided. And of course, the side that is affected is the one that's going to give you the presentation. So when it's the left side of your brain that's shrunken, that means you lose the meaning of words, objects, emotions. And, you know, when people think of losing meaning, they have to realize that it's actually a profound loss of meaning. Like people, it's not just that somebody has lost the word for fish. People don't even know what a fish is. They don't know that that's edible and that their plate is not edible. So you lose, you know, the whole spectrum of what is encompassed by meaning. And so the way we diagnose this is, you know, we give people pictures, and they can't figure out the name. They have trouble even understanding what you're saying. If you say, like, give me an eraser, they'll be like, well, what is an eraser? What does it do? So it's really distressing. And, you know, initially it's only like the low frequency words, things that you don't, you know, use that much, but eventually it's even high frequency words. So, you know, they would lose the word for cup or fork or car. They also have difficulty reading, because if you don't actually know what something means, you don't know that ISLAN should be island. You know, it's island. And the word next to it is not colonel, it's colonel. So that's also what we use to make these diagnoses. And to try to get more certainty, what we do is we look at the brain. And if we look at the brain and we see shrinkage in a very particular pattern where, you know, the rest of the brain looks pretty good, it's really this one area that is super shrunken. The pathology of this disease is actually almost 100% called TDP43, and it's a certain type. And, you know, when we compare it to controls, we see, you know, where the brain is shrunken and giving these people the problems that they have. This disease also has an early age of onset, but the progression is actually very slow. These are patients, we say 5.2 from diagnosis as a like an average, but actually I have many patients who live way over a decade with this condition. And this condition can also affect the right side of the brain, and it's called a right temporal variant. And the reason it's important to know that is because these people, they don't have any trouble with language, with the meaning of words. They actually have a problem with, the meaning of social norms. So understanding how you have to act in public or with other people. And what does it mean when you say somebody is your mom? What goes with that? And so they often will have difficulty recognizing emotions. They will not have any empathy. But really what they lose is person-based knowledge versus when you have the left side where you lose the meaning of words. Non-fluent is the opposite. These people understand, at least early on, they understand quite well, but they cannot express themselves. Very frustrating. They know what they want to say. They remember the word they want to say, but it does not come out right. So a lot of times people, well, they sound a little bit like what people sound like when they've had a stroke. And so it often gets confused. These people sometimes get evaluated for stroke because of how they sound, but really they have problems where they can't get the word. They have a motor problem to get the word out, and eventually they're become mute. Some of them, that inability to get the word out, that motor programming problem spreads and can go into other areas so that they'll have trouble using their arms, their legs, and eventually it spreads to the other side of the brain. So initially it's just the right arm, the right leg, because of course it's the left side of the body of the brain that is affected initially in non-fluent variant. And some people, it's always just stays in that motor part. And so from when they get the disease to when they die, everything else is pretty good, but their language, their ability to express themselves is bad. And so again, we make diagnoses based on, giving them pictures, telling them to repeat words, and seeing that, their comprehension, their understanding is actually okay. And, to try to get more definitive diagnosis, we look at the brain. And again, like I've said before, we look to specific areas and see that there it's shrunken, but the rest of the brain actually looks pretty good. In terms of the pathology for these people, it's usually what we call tau, but it can be other things. So this is another group where it's going to get really tough to figure out what treatment to give them. And this is 25% of FTD belongs to this category. It has an intermediate rate of progression and intermediate rate of genetic cause, but usually it is tau. What about Corticobasal syndrome? This is a disease that includes motor problems as well as cognitive problems. So the motor problems are not that easy to understand, in the sense of it's people who can't use their limbs properly, but they've not had a stroke. They have no paralysis, but it's kind of the motor programming of what they want to do that has broken down. So we take it for granted that if we want to reach for a cup and get it, we can do that, right? Or you just extend your hand, and as long as you get to the cup, you're okay. But these people, they know what they want to do, and they tell their arm to do it, but their arm doesn't listen. And so sometimes it doesn't move at all. Sometimes it moves to the wrong area. But at the end of the day, they're quite debilitated because these people lose the ability to dress themselves, to eat by themselves, to brush their teeth, all kinds of things. And sometimes they also develop what we call Parkinsonian. So they become slow, they can develop a tremor. And over time, they do also develop cognitive and behavioral changes. And in some cases, you can actually start with those. You can start with a cognitive behavioral change and then develop all the motor symptoms afterwards. Progressive supranuclear palsy is a different disease. Actually, this disease was described 59 years ago today in, not today, but this year in Toronto for the first time, where some people got together and started to describe a group of patients that they saw that had this kind of constellation of symptoms. They would fall. Their eyes would not move. They couldn't look up and down. They looked a little bit like Parkinson's, but not really, because they, their limbs moved better than their trunks. And they had cognitive changes that were, a particular pattern. And when you gave them a medication that you give to Parkinson's, it actually didn't work. And they had a much lower life expectancy than in Parkinson's disease. And then we realized that actually that original syndrome was only one, and there's actually many ways you can present and have the same pathology. And so, we've now refined our criteria and look for different forms of PSP. And the reason to do that is because, making the right diagnosis is kind of the first step in getting a treatment, right? Like you can't treat something if you can't even figure out what somebody has. And so now we realized that we had missed a lot of people with PSP who had gone to autopsy. And, sometimes autopsy is, very revealing. And, you would figure out that actually you got the diagnosis wrong because, you thought it was something else. What about genetics? So, a lot of people are worried about genetics these days. And I hear that a lot from my Alzheimer's patients. But in Alzheimer's disease, it's actually not that common to have a genetic cause. To have, a primary genetic cause of Alzheimer's disease is probably less than 5%. And that's even in younger people. Whereas that's a different story in frontotemporal lobar degeneration, where 40 to 50% have a familial and we think genetic cause, even though sometimes we don't find it. In 10%, it's autosomal dominant. So that means that, if a parent has it, and that's 10 to 20%, unfortunately, if a parent has it, every child has a 50% chance of also having it. And there's two of the syndromes that have the most, let's say, strongly familial characteristics. And there's three main genes in frontotemporal lobar degeneration. There's something called a C9 expansion. There's a microtubule associated protein tau, and there's progranulin. There's also these other ones that are very rare, but those three make up the bulk of the patients that have frontotemporal lobar degeneration due to genes. And, the interesting thing is that when you figure out that somebody has a genetic cause, it helps you in terms of knowing the pathology. So that's always good. But it doesn't help you with the clinical syndrome, because a lot of the genes can be associated with different types of syndromes. So you can look at, this one that's called C9, and you'll see that it appears under ALS, it appears under frontotemporal with ALS, but it also appears under behavioral variant. It appears under non-fluent variant. It appears under Corticobasal syndrome. So of course, then, when somebody's asking you, well, what will I get now that you have found this gene? It's hard to predict, because when people have genetic causes, a lot of times their families will be tested. And in some cases, they want us to try to predict what they're going to get, but it's very difficult. And the same is true when you look at the syndrome. So let's say we look at behavioral variant frontotemporal dementia. Well, you'll say, oh, well, there's C9 that can cause it, but progranulin can cause it, and MAPT can cause it, and this VCP and CHAMP2B can cause it. So again, it becomes very difficult to identify, the cause of somebody's syndrome when there's so much heterogeneity there. And so, this is a disease, a family of diseases that really highlights that we need precision medicine in neurodegeneration, just like we have it in cancer, where, to get a treatment, we dive deep down, right? You have to have like molecular precision to get a cancer therapy these days. Well, in the brain, we weren't like that. But in this disease especially, it becomes very important to think along those lines. The other thing that genetic FTD has taught us, and this is true for all diseases that we know of right now, is that these diseases start long before you show any signs of disease. So at least in the genetic cases, we know that there's shrinkage of the brain in areas, but the patient is completely fine. We don't see any clinical sign. And so we think the brains are compensating, but eventually the brains cannot compensate. I don't know if you can see that, but that estimated years from symptom onset is at the far end there, it's like 25. So 25 years before you show any signs of disease, the brain is already starting to change. I talked a little bit about this, that, you know, there's basically two, tau and TDP43, that make up the largest bulk of the pathologies. And so a lot of us exert a lot of effort trying to find better ways to detect these underlying pathologies while the person is alive. A lot of the work that you see is, you know, post-mortem. That means a person has died, but that's not going to help us trying to get treatment, getting the right treatment to the right person. So we spend a lot of research hours trying to figure out how we're going to be able to detect this in people while they're still alive so that we could deliver the right treatment to them. So that brings me to the treatment part. So right now, we don't have any medications that can cure or delay progression. And we do have, though, medications that are for symptomatic relief. So we do have things that we prescribe to our patients if they have anything that we can treat. So whether it be pain, whether it be depression, if they have motor problems, but we don't have anything that will change the course of disease. This is, however, a very active research area. So there's natural history, trying to understand more of the disease and, with the goal of being able to treat, as well as many treatment trials. We actually have quite a number of treatment trials in progranulin carers. What we have less of is treatment trials in people who have what we call the sporadic or spontaneous form, so no genetic cause. And so, I always urge people to, participate in research if they can, because it's really the only way to help discovery. We need to figure out ways of diagnosing people early on. We need research to help us understand the pathology, like what's gone wrong, why is it so different? Research helps us understand this heterogeneity. There are registries for future clinical trials. So when you're part of that, you can, get to know about a treatment early on. And this is how we're going to discover new treatments. You may have heard or not heard, but there's actually 2 drugs that have been accepted by the Federal Drug Administration in the US for Alzheimer's disease. And, it's taken decades to get anywhere in that illness. And there have been hundreds of trials that have failed. So we're, hoping that in the next few years, we actually have something for FTD. So I'll tell you about 2 different studies, and these are what we call observational studies. So we're not giving any drugs. We're just collecting a lot of information to try to understand first how to make a better diagnosis, how to track the disease over time. You may or may not know, but when we do clinical trials, we have to know what happens. And so if we gave a drug, we would know, well, there's a change in what happens, right? Like that's how you evaluate if a drug works or not, because you can say, oh, well, the progression is not the same as if you didn't give the drug. And so this study called Artful Lefties Longitudinal, that's based on the fact that these are frontotemporal lobar degeneration, both sporadic and familial. So it was the combination of two studies that basically recruits people who have a diagnosis of FTD, any of the 6 syndromes I told you about, or they have a family history of frontotemporal dementia. So we have a lot of people actually that don't have the disease, but they have a gene or they have a family member with it. And we follow these people over time. And really it's to identify clinical assessments and tools that are sensitive to change and find better biomarkers that, could, 1, diagnose, 2, predict when somebody's going to, develop a disease. Let's say you have the gene, but you're 20 years old. Well, will you get it at 40? Will you get it at 60? And then to track the disease progression. So we take people who are 18 years of older, have a study partner. They have to be able to read English, and that's only because a lot of the testing is done in English. And then we also include people with all kinds of syndromes that belong to frontotemporal dementia, so the 6. And the only real exclusions are that, we have structural brain lesions and that we know there's Alzheimer's disease, or that, people have some history of something that, makes a big difference to their testing, and uncorrected B12. And so as part of the study, they would get neuropsych testing, they get blood draws, they get MRI, we look at their eye functions, and, all this data is put together, and, we do give that back to the patient to let them know how they're doing and follow them over time to see how things progress. There's another study that is similar, but slightly different, only that this one is focused on this 4-repeat tau, which is basically a form of pathology that affects corticobasal syndrome patients and affects PSP patients. So this study just focuses on those 2 groups of patients. And the reason that it was separate was, 1, it was just kind of the way we started before the other one, but also because in this study, we're including some PET measures. And in this study, we're really also trying to find better ways to make a diagnosis in people who are at earlier stages of disease, finding ways to track this disease over time. And so similar criteria, there's similar testing that is done. The only addition here is that there's actually a PET scan, which is that colorful picture at the end. And, that's because with this study, we're actually trying to label that bad tau and see whether we could find a way to make this diagnosis at earlier stages. One unfortunate thing in patients who have these conditions is, unless you have the genetic cause and somebody in your family has it, most of our patients are getting diagnosed at very late stages of disease. And that's not good, right? Because we know now that we have to try, initiating a treatment at early stages. But if it takes years to get a diagnosis, and most of our patients, it takes over 3 years to get a diagnosis, that's way too late for treating them in a way that makes sense to reverse or preserve their function. And so to conclude, frontotemporal dementia is a family of clinical syndromes that have behavioral, language, and motor impairments. And the frontotemporal lobar degeneration includes 3 main pathological substrates. Usually, though, it's tau and TDP43 that are seen. Genetic cause is common, and I urge everybody to join research if they can, because I think that's really the only way to move us forwards towards a cure. So thank you for listening, and happy to take some questions. Well, maybe I'll stop.